patients who are terminally ill. And the participant hopefully will understand ways to cultivate the 4 dimensions of hope, not only in their patients' lives, but also in their own life. Now, as I get started, I think it's probably important for you to understand a little background as to what got me so interested in the concept of hope, especially at the end of life. As Beza mentioned, I was a nurse for 30 years before I decided to shift over to spiritual care. And I have to admit, out of all of the different changes in my career, I do believe that that was the most difficult shift I have ever made. The reason being is, oh, that's the outline. Sorry, I forgot to skip to the slide where I'm talking about. The reason being is from being a nurse to a chaplain, nurses have a tendency to be geared up to need to fix things. That's what I was trained to do, not only as a nurse, but a nurse practitioner. You have a problem and you do what you need to do to fix it. When I was suddenly asked to enter patients' rooms of people I did not know, with no agenda and no real mission as far as having an absolute thing that I was supposed to do, it was a bit overwhelming to just be there and trust that the moment will unfold as it is supposed to. And what I found particularly difficult was when I was asked to see patients who had the difficult conversation with their medical team about the fact that there were no further treatment options. And what was difficult for me, as I realized in my early training as a chaplain, is that my hope, because of my medical background, was the hope of finding the next treatment. I worked for years at NIH, and that was very much the way things seemed to unfold, where if there was one protocol that didn't work, we searched and helped people hopefully get another protocol, and it went on like that. So it really was a struggle for me, because I knew as a chaplain I better figure this out, because I knew there must be much more to this hope thing that chaplains are aware of. And so it was a pivotal moment for me. Either I understand the concept of hope at a broader level, or maybe reconsider my career options as a chaplain. So I took 2 years to explore the literature, and I was grateful that they allowed this to be my seminary thesis. And as Beza mentioned, I was also grateful that later it was able to be published into a book. So let me go over briefly my findings in the literature review, because I think that really shapes the framework. So let me start. It's basically in chronological order, and it really was fascinating to see how hope emerged. And as I have on the first bullet point, is the concept of hope emerged in the medical and psychological literature in the 1950s. A researcher from Robin Downey from the University of Glasgow, he was one of the earliest researchers to define hope. He placed hopes into 3 categories, emphasizing a person's process of hoping. Erik Erikson, the well-known psychologist known for the stages of psychological development, some people call it stages of change, described hope as a human quality. And this is an important thing he wrote about. He said the most mature hope being that of faith, which is not having to have evidence or reason. And I'll repeat that. The most mature hope being that of faith, which is not having to have evidence or reason. In 1965, Abraham Hoffer, a physician and scientist, declared the practice of medicine had replaced hope. So the mature hope Erikson described, based purely on faith without evidence or reason, became hope in scientific discoveries. Christina Pachulski, and many of you may be aware of her, she's well known. She's a director of the George Washington Institute of Spirituality. She described that the source of hope became focused on science and its ability to cure illness. Healing became synonymous with cure. Now, everyone's familiar with Elizabeth Kubler-Ross, who did all that work talking to patients and doing just a vast amount of qualitative research, discovering the stages of the dying process. And what she discovered is the one thing that usually persists throughout the various stages is hope. But, and this is important, the hope that she referred to was the hope for a cure. She believed it was important to maintain a person's hope for a cure, even if a cure was not possible. Bruce Rumbaugh, he's a professor of pastoral studies, called this type of hope for recovery. He describes this as the only type of hope that the medical establishment focuses on, because the assumption if you tell a patient they are dying, they may become deeply depressed. Gregory Anderson, a well-known author on this subject of end of life, described the fact that the medical profession often feels a sense of failure when an illness is not cured. Death had become the enemy. This sense of helplessness by the medical provider can be avoidance. It can cause avoidance. And, you know, I have to say chaplains are not immune to that avoidance. According to Rumbaugh, they often retreat behind liturgy rather than risking a deep personal encounter with the dying. Rumbaugh declared that in order for hope to emerge, a person needs to have a realistic assessment of their situation. And I have to say he was ahead of his time, because he said this before patients had the legal right to full disclosure of their medical information that began in the late 90s. When people were no longer being kept in the dark about their prognosis, the literature on hope began to expand. However, as Dr. Jerome Groopman, who wrote the book The Anatomy of Hope, How People Prevail in the Face of Illness, described, that maintaining hope in patients was important, but as well as admitting to the sense of helplessness. And this sense of helplessness continues to be a struggle for many physicians. He writes about the importance of maintaining hope in patients, but not necessarily the hope for cure. By observing honest end-of-life discussions, Groopman and others discovered many ways that their patients exhibit hope. This indicated an important turning point in the literature where hope was finally no longer placed in just one category, the hope for a cure. I've listed some of the major researchers and theologians who have been pivotal in defining different ways people exhibit hope at the bottom of the slide. I found that all of their descriptions about these experiences can be placed into 4 dimensions. These 4 dimensions are what became the foundation for my hope framework. I call these dimensions hope that, hope in, hope with, and hope in the present moment. And now I'll go through each one so that hopefully you'll have a good understanding of them. So when it comes to applying them in the framework, it will make much more sense. So the first is hope that. So hope that, and again, this all came from the literature. Hope that is a type of hope that I read about that is more external. It relies on someone or something to fix or change a situation. Now, it's really actually the most common hope that we have. It really drives us. If you think about it, we're often, as humans, wanting things to be better, wanting to fix it, wanting to change it. This is what motivates us. It motivates us to go to the doctor. If we didn't believe that there would be a treatment or improvement, we wouldn't do that. So it's probably one of the most important dimensions of hope, because it really drives us and motivates us in life. Examples of hope that are hope that medicine will find a cure for my disease. Another interesting example is hope that God will perform a miracle. So again, this is sort of that sense of an external situation that will fix or change what's going on. Now, at the context of the end of life, if these are the only types of hope, if this is the only type of hope, the hope that something will fix or cure or change the situation, and the person doesn't see this happening, they can fall into despair if this is the only hope that they're aware of. And we often see that this can lead to spiritual crisis. Now, hope in is the internal hope. It does not rely on someone or something to fix or change a situation. Ultimately, it is the ability to be able to let go and trust, recognizing that not everything is in our control. Erik Erikson actually described this, as I mentioned already, as that mature hope based on faith, not having to have the answers and just trusting, and having a sense of inner strength and inner peace. This type of hope is very personal, and it's often hard for a person to describe it. Some people just have a sense of it, and some people really, really struggle with it if they haven't really spent time thinking about it. This type of hope in, is heavily based on afterlife beliefs when you're dealing with patients at end of life. And these can be beliefs that are religious and non-religious, which I'll go into a little more later. Hope in examples. Here are some. Hope in a power greater than oneself and greater than medicine that can provide a feeling of strength and peace. Hope in a belief that life does not end with this life. Hope in being able to let go and trust, knowing, again, that not everything is in our control and that some things are beyond our human capacity to understand. The invitation of knowing that we've been invited to a great mystery. Hope in knowing we have been, that's my last bullet point. And the next one is hope with. So hope with is the third dimension, and hope with are those relationships where there is open and honest communication. It's that circle of people in our lives that are the inner circle, the people that you can count on no matter how bad things get, during the good times and the very difficult times. This can often need reconciliation for some people, because there are people who recognize as they are facing the end of their life that there were people in their lives that were in their inner circle who no longer are. And sometimes they face the fact that they need to maybe deal with some reconciliation of old wounds. Hope with examples. Hope with is having that inner circle, again, of friends and family who will hold me in my suffering. Hope with is having people in my life who I can have honest dialogue about my concerns and fears. And hope with is knowing I will never have to worry about being alone. Now this, and the reason I have an asterisk, is this can also come from a very strong belief in God or a higher power, that sense of never feeling like you are alone. And finally, which ended up being my favorite category that I discovered or dimension, is the hope in the present moment. And this is the hope that comes from being able to let go of the past, not worry about the future, and be in the now. And we all know the term mindfulness, which we hear a lot of these days, and it's so important. This very moment is the only one we are all guaranteed. As long as a person is breathing, alive, it's important for them to focus on the fact that that in itself can be hopeful. Just that moment that they're spending with a loved one, doing something they enjoy, and to encourage that. So examples of hope in the present moment comes from the ability to appreciate, again, the very moment we are in. Hope in the present moment comes from the ability to be completely present with our friends and family. Just really paying attention to that dynamic that's going on, no matter what's happening at the moment, whether it's good or bad. And hope in the present moment is being able to see every moment as sacred or precious. Now, I want to circle back to hope that. And the reason being is, I mentioned at the beginning examples of hope that my illness will be cured, or hope that a miracle from God will occur. these are examples of hope that, and again, as I mentioned, if we find that someone is only relying on that type of hope and they're finding that those things are not happening, it can shift hope into despair. But what we do see as people are transitioning and having more acceptance in the situation that's happening to them as they face end of life, there are other hope that's which emerge. So these would be that they hope that their pain will be well controlled. They hope that they will have a peaceful death. And this one is really very common and important. A person hopes that their family will be well taken care of after they die. Now, it's important to know that none of these hope dimensions are mutually exclusive. They're not linear. There's no set pattern to them, and everyone has a different degree of them. I firmly believe everybody has the capacity for all of these types of hope, and sometimes our job is just to help them recognize these dimensions. But again, and this next slide shows it, it's dynamic, it's not static, and it changes. How people view their hope at one stage of their illness certainly can change, dramatically depending on what stage they're in of their illness. So how do we use all this information, these 4 dimensions, in a framework? So that's what I would like to cover next. But do you think this would be a good point to make sure that nobody has any questions about those?
So if you have any questions, you can go ahead and put in the chat box. We covered a lot so far. So for me, what I wanted to ask was, you said they're not mutually exclusive, but could it be problematic if a patient or client is stuck in one of the dimensions, specifically the hope that, which is which you talked about it as a way of an external, hoping on that something in the external can be. So have you seen a problem in that arena, and how did you, from your own practice, resolve it?
That's a great question. Yes, and I think there are some people that do get caught up in that hope that, and it's understandable. I mean, if you are facing the end of your life, and most people don't necessarily want that to happen, especially younger people. It's important, I think, to recognize not necessarily that they're stuck in it, but to recognize that it's important to them. It's we don't take any area of hope away, but gently sort of shifting or reframing other areas of their life that they can focus on, that fill in these other dimensions of hope that they can fall into, to give them the strength that they need once they recognize that the possibility of that cure is no longer going to happen. So our job is to help them recognize these other dimensions.
So meeting them where they are?
Meeting where they are, and providing them subtle ways to look at where they're at now, what's going on in their lives, where things are headed. And I think some of this will come up more as we go through the framework. But yes, that's the role, is to help people shift and recognize, that there's more than one dimension of hope. All right. So how do we use the framework? We kind of touched on it. First of all, what we're required often to do in our roles as spiritual care providers, and I know a lot of medical areas are now having others, such as social workers and nurses, even physicians, thinking about spiritual assessment, is we collect data. There are certain questionnaires which are really more geared to helping people remember types of questions to ask. And I'm not going to go into detail about the questionnaires because that's not the point of this conversation. But the bottom line is asking questions and collecting data is part of how we know where people are at, and it's part of our job to assess. So once we have this data, sometimes we have a lot of information that people have shared. Hopefully, they share their stories and their illness review and their life review. what is important to look at is what hope dimensions are in the data. And this is what I tend to think about. And are there any that they are focusing on heavily, and others that maybe they need, as Beza had me discuss, maybe they need a little gentle encouragement to think about other areas of hope. What hope dimensions are missing? And that is really key. And then once this is recognized, the plan of care can be based on supporting the hope dimensions that are in the data, because there are some people that amazingly got pretty much everything covered. You meet those people, they're just sort of pretty amazing in their resiliency to what is happening. But the other is writing about ways to cultivate the hope dimensions that are missing. Now, I'm not saying that you write in your plan of care the word hope and this and hope. It's just a way of categorizing in your mind that that there may be areas that you can provide that will help them in these shifts to the different dimensions that are available. And I'll do a case study at the end that I think will bring it all together. So cultivating hope, again, is what our role is really helping people to recognize that, yes, they can cultivate these other dimensions of hope, and we can cultivate them in our life. So let's start with hope that. So you may have somebody in the data says, well, I hope that there are other treatments. Well, again, as I've mentioned, there's nothing wrong with them hoping for that, and allow them to discuss other treatment options if available. And certainly if there are information that they can receive or other professionals to talk to, don't hold back and let them do what they need to do for that type of hope. The hope that I will have a peaceful death, that would be discussing symptom management and their wishes. Hoping that my family will be okay after I'm gone. So this is important to get people to recognize, because this is where you'll be encouraging people to get their affairs in order, make sure that they have a healthcare power of attorney, financial power of attorney, and their advanced directives to communicate their wishes. And hope that I will be remembered. This is another hope that people don't realize is important to them until you have a discussion. And some people actually want to write their own obituary or plan their memorial service. Other ways to be remembered, creating a scrapbook or writing letters. I think writing letters is very powerful for some people, especially if they want to pass along messages to the next generation, for whatever reason. They really need to be encouraged sometimes that would be an important thing to do. Now for hope in is sometimes a little more complicated. Hope in can be a person's particular religious dogma or framework, and if they have a particular religious dogma or framework, that's beautiful. Encourage a reflection on their beliefs. Let them express that. Support positive beliefs, but in the back of our mind as chaplains, we often want to be sure that we reframe some maybe more negative beliefs. For example, if a person has a strong sense of God of punishment, one of our roles is to maybe help them shift to thinking about a God of love so that they may not feel so alone. Hope and believing in an afterlife, this, again, for religious can be a specific theological framework. But for the non-religious, it certainly means legacy, and that's true of religious also. Legacy, how you've impacted others in your life, the love that you've provided with your family will be passed on to their family and to their family, and that's a sense of living after death. And hope in knowing life had meaning, so giving opportunity for people to do that life review so they recognize that even an illness review, in doing that, they can recognize maybe some meaning in what's happening, and again, the impact that they've had on others. For hope with, to cultivate that. Hope with is, again, based on support from family members and friends. This is important to encourage people to have honest dialogue. I've mentioned before the reconciliation. Sometimes people need to be encouraged to reconcile, especially if it's really troubling them. Encourage openness for help. I think this third point is really important because so many people face difficulties and they feel that they don't want to be a bother or they don't want to be a burden. And not to broad brush, but I think for many women who have always been the care providers in the family, they often feel like they don't want to receive the care. So as we know, that can be something really important to help them cultivate hope with. Hope with based on support from communities, people who are in a community of faith or another type of spiritual community. And I think important to recognize for some people, work relationships are a community. So encouraging contact and openness with their faith leaders. Sometimes it includes also with supervisors and coworkers and other group leaders. I have the last point about HIPAA at the bottom, and I raised this, and again, this could be a whole nother discussion. And anybody out there who's thinking about research work or PhD work, I think this would be a great topic, and it isn't going to be me. I'm done. But since HIPAA came along, to me, I've noticed a pattern of more isolation with people, especially older people. It used to be once somebody knew somebody was having health problems, you know, it spread like wildfire that everybody was aware of it in the neighborhood or their church or so forth. Now everybody's very aware of confidentiality, which I think is important, don't get me wrong. But in some ways, I do think that there's more of a trend now of people feeling more isolated. And that's just something I toss out for some thought. And lastly, hope in the present moment. And I think most people that I'm talking to are aware of all kinds of different ways for ourselves and to help encourage our patients that we can do this. Guided meditation is a wonderful way. People who have never meditated before, a guided meditation is a beautiful way to help them understand what meditation feels like and how to go through a meditation. And there are many apps on doing guided meditations available. Encouraging someone maybe to do some art, music, listening, or if they do music themselves, writing, journaling, poetry, writing. Meaningful conversations, honest, really down and deep conversations is really being hopeful in the present moment. Being in nature. And for some people, inspirational reading, such as scripture, prose, or poems can offer that. So now I will go ahead and move into the case study. Okay. So what we have here is we have Mrs. K. Mrs. K is a 43-year-old white female with stage 4 breast cancer. So after spending a good portion of time talking to her and gathering details about her life and what is happening with Mrs. K, these are some of the main themes that popped out. She was diagnosed 2 years ago, has I know how to say metastasis. Just stumbled right over that. Metastasis to the liver, bone, and brain. She's on 4 treatment regimens. She's had 4 treatment regimens, including 1 phase 1 clinical trial. She's a grant manager for the government. She never married, has no children. She has 1 sister and a large circle of friends, but does not want to bother them. She was raised Catholic, left the church as an adolescent, and states that she does not believe in God. She states that she does not have any hobbies. She works, and that work is her hobby. And what is most important to Ms. K is to find treatment that will cure her cancer. So these are some of the main pieces of data that were obtained by your assessment.
So can we give the audience an opportunity to see if they can identify where we see the hope that, or any dimension of the hopes that we've discussed so far? So
sure. No, that'd be great.
I'll give you a few minutes to see where you see any of the dimensions that have been discussed so far.
Yeah, what you could let me know is where do you see the hope dimensions, and where do you see where hope dimensions could be cultivated that may not be mentioned, that she may not be aware of. Again, I think everybody has these dimensions, but they may need guidance as to being more aware of them. So that would be great if you guys did that. I think that'd be really.
Susan says, hope that a cure is possible.
Mm-hmm. That's definitely a big hope that for Miss K.
All right. It seems like, yep, her legacy.
Yes, that would be very important to focus on for her, especially since and we'll go into this when we go through it, but especially since she's now having this sense of no sense of God, or maybe not an afterlife concept. We don't know till we actually talk to her. But for her legacy and the contribution she's made in her life, as her future story could be very important. Yes, I'm reading along these comments. This is so cool. I'm used to doing things live, so bear with me. Yes, nurturing, being open to help from her sister and friends. This is huge. She at least admitted that she doesn't want to bother them. So this is a really, this would be a very large place to put emphasis and help her through recognizing that it's okay, to ask for help, so that her hope with will, be cultivated. Perhaps present moment in communication with inner circle. Yes, exactly. So, and again, here's that overlap, the fact that if she's able to bring people closer in and ask for help and have those intense conversations, that absolutely is hope in that present moment. Absolutely. Very excellent. I don't see any new ones.
Continue. Oh, you could keep them coming, and we're going to just, in the interest of time, we're going to continue on with the presentation.
Yeah, with the last one, yes. That hope that her friends, let her know that her friends want to help. Yes, and that, and I love that comment, because I think people don't recognize, and I've seen, you probably all have too, those aha moments when, if you yourself like to help other people and feel good about it, helping them recognize that they too, your friends, feel good about helping, the person. So yes, that is really key. So this schematic, I think, helps give a visual of some of the key things that we've already brought up in this, discussion. But I'll just hit the bullet points that are listed here. And the way that I've set this up is the blue is the assessment, and the pink is the plan. And in the middle is, the different hope dimensions. So we'll just go through, and again, I think we've raised a lot of this already, but we'll just describe it a little bit more detail. So Mrs. K believes that the right treatment will cure her. And again, we talked about this. There's no reason for her not to continue to believe that and support her. I think that, in time, as we see that people do over time transition, some people transition, it takes them a lot longer. Some people maybe never transition to giving that up completely. And again, our job is not to take hope away, but to foster and support hope. So that was the one upper left. Lower left, we've talked about a lot about the fact that she has this large circle of friends but does not like to ask for help. And yes, really working with her to encourage her to ask for help is vital for cultivating her hope with. She, as we all know, in time will need more help, and getting her geared up for that would be extremely important. Now we'll go over to the right-hand side for the comment, or I mean the assessment that she is non-religious. So let's go a little more in detail with that, because I do think, and here I am the chaplain, and I'll be the first to admit, sometimes hope in is complicated. Again, it's very personal, multiple layers. It varies whether somebody is highly spiritual. It varies about culturally. It varies if they are religious versus non-religious. It's a very personal journey to where they have existed. As I had recently said to a patient, spirituality is like snowflakes. there are no spiritual paths alone. And but our role is to meet people where they are in that spiritual path, if they are willing to talk about it and work through different thoughts, concerns, and that's a major part of what the spiritual care role is. And so I'll go over a little bit of my thoughts with Mrs. K being non-religious, which may be helpful to shape the way that this would be addressed. The fact that she was raised Catholic and gave up her religion, and she now states she no longer believes in God. So someone without a strong religious underpinning often needs a little more guidance to help them understand that they do have hope in. They do have an inner anchor that keeps them going. And some people just may not be aware of that. So at that point, it's important for us to help them explore what gives them strength now, because they're going through an awful lot. So something is helping give them strength, and what gave them strength during other difficult times in their life. I mentioned the word future story, and I think this is important. Donald Capps, he's written books on hope, and his main discussion about this is ask people what their views are of their future story. What are their concepts of afterlife? I think people get a little nervous by asking a question like that, but it's interesting, and people usually want to talk about it. Just because she is no longer religious and says she doesn't believe in God doesn't mean she doesn't have some sort of a concept of an afterlife. She may think this is it, but she also may have this thought that there is something beyond this. She can't name it, or she doesn't have any set framework for it or dogma, but she may still have a sense of feeling that there is something beyond this, or not. And it was raised in our open questioning time. Yes, I think for her, getting a sense of what her contributions are, especially what she is making now, and I say making in the present tense because she's still working, and working is very important to her, and she says basically that is her hobby. So helping her to see what contributions she is making and what she will be making for the future, and exploring how she finds meaning in life. What she believes will be her legacy will most likely, as we mentioned before, be key in helping her cultivate and discover her hope in. So, for someone like Miss K, helping them explore hope in can be very multi-layered. For somebody who is highly religious, had a very strong belief system, again, we meet them where they are, and if it's giving them a sense of comfort and peace, we support it. I mean, that's just wonderful. So then the last category, hope in the present moment. So for Miss K, she did say that she has no hobbies and that work is her hobby. She also, and I don't think I have this as a bullet point, she says she's always looking for the next treatment, has no time for anything else. And, again, don't take that hope away, but maybe gently encouraging her to explore other areas where she can be in the present moment. She may have loved art as a child and had forgotten that and reintroduce her to that, or maybe never allowed herself to have fun with those kind of things. So again, it's a matter of just giving her opportunities, suggestions, and there are multiple ways to help pull people into recognizing that hope in the present moment. And as someone shared in our comments, yes, having those meaningful conversations with friends, being open and honest, and allowing that inner circle to really tighten up. It's in those moments that there is hope. So that kind of puts it more into how the framework looks. I think I'll open it up to questions again.
Yeah, we do actually have a question from Pamela. Can you tell us how to support belief in cure when there actually is no cure? As a healthcare professional, I feel that informed consent implies patients have realistic expectations. Very good question, Pamela. So can you
yes, no, and that's an excellent question. I don't think there, yeah, and there's a real risk of false hope, giving people false hope. And I agree with you. I think being honest with them and saying there are no treatment options that we know of. I know we're going to do everything we can to keep you comfortable. Yes, we don't. That's such an excellent question. So thank you. I'm not suggesting that we say yes, there might be something else out there. Encouraging that. But at the same time, if their determination is such that they just have to keep looking, and I say this from a personal experience with a patient I had who had a research background, so I mean, how can you stop that? That just was on the internet constantly, knowing that there's got to be a trial somewhere because a trial can pop up at any moment. If you have somebody who that's driving them, you can just you can support it by just not saying you're wasting your time, because that would be very much of a blow, but certainly not encouraging it, certainly not saying anything that's false as far as the reality of the situation. I hope that makes a little more sense, because that is an excellent question. It's just that if they really feel driven to keep looking, and eventually, this person, did come to terms, but it had to be her terms. And I think that's what's important. Oh, good. So again, I'm so used to doing this in person. I hope you're smiling. You're welcome. Again, that was such a terrific question, so thank you. Any other questions? Okay. Well, I just want to, so someone asked about, is my book available? Yes, it's available on Amazon and Barnes & Noble, and through the publisher in London, Jessica Kingsley Publishers, so you can obtain that. And so just final thoughts. My final thought is no one should ever face the end of their life without hope. It is important to cultivate all these dimensions of hope in the lives of those we serve and in our own life. Hope should not end when medicine can no longer sustain us, because hope is the ultimate sustainer. And I love this quote: hope is the deep orientation of the human soul that can be held at the darkest times. So that's it, and thank you.
Thank you, Laura. This is a perfect time to ask any questions you may have, and I won't even disturb this and add on this. This is a perfect way to end it. We do have about 10 minutes, so if you have any questions, feel free to type them in the chat box. My colleague Mindy right now is sharing a link to the evaluation form. It's very important to complete one of these, especially if you need to see a social work CEU. But anyone else, really, we love to hear from you. Your feedbacks help us improve our programs. Also, we like to hear about what you want us to cover next. The next, like I said, we would share any resources talked about today with you in the follow-up email. This is a first exclusive program for the certificate in healthcare candidates. The next one would be an in-person program on April 2nd. It would be at Hebrew Home, and this is going to be one of our half-a-day workshop. It's going to be on bringing how we can bring equity into end-of-life care. It's going to feature a lot of healthcare professionals, most of them physicians, discussing about cultural humility and advanced care planning, but from the perspective of bringing equity into end-of-life care. That is going to be also an exclusive program, like I said. I will share the link, registration information with you next week. We also have a fast track program if this year's graduation is going to be in September, and if you want to knock 3 of the courses in one setting, this is your opportunity to do it. On March 12th, we're offering 3 of the core courses also in person at Aspenwood, and we still have a few seats available. So if you have any questions or want to register, you can go ahead on and register on Eventbrite. And you receive a $10 discount, and if you need a discount, the discount code, you can just email me. Thank you all so much for joining us, and we hope to see you soon. If you don't have any questions, I'm just going to end it here.